and introduce you. Okay, it's my pleasure today to introduce Dr. Nana Gletsu Miller. Dr. Gletsu Miller is an associate professor of applied health science in School of Public Health at Indiana University, Bloomington. She obtained her PhD in nutrition and metabolism from University of Alberta in Edmonton, Canada. She then underwent a postdoctoral fellowship in pathology and molecular biology at Emory University. After that, she served as an assistant professor in surgery at Emory and then as assistant and associate professor with tenure in nutrition science at Purdue University. And that's where I actually met Dr. Gletsu Miller. I was very fortunate to have her on my dissertation committee. She is currently serving as the chair of the Obesity Research Interest Section of the American Society of Nutrition and the Advocacy and Science Policy Committee of ASN as well. The vision of Dr. Gletsu Miller's research program is to evaluate nutritional solutions to promote the health of individuals undergoing clinical management of obesity and diabetes. One focus of her research is developing effective and safe treatment strategies for improving nutritional outcomes following bariatric surgery. And a separate research program focuses on the prevention of youth onset type 2 diabetes in adolescents who have obesity and prediabetes. Dr. Gletsu Miller employs a diet and a nutritional supplement interventions to promote nutritional status and cardiometabolic health, and she uses state-of-the-art anthropometry, biochemical, clinical, and dietary methods to assess nutritional status. So with that, please join me in welcoming Dr. Gletsu Miller today.
Thank you all. I'm going to share my screen and then I will start. Thank you very much for that really nice introduction. Can you all hear me fine? Good, and see my screen? Great. Good. Yeah, I really wish I would have been able to come in person and meet you all and get a sense of your program and your department and your seminar series. And these are all things that I aspire to over here. So here in Indiana University. So anyway, and of course, catching up with old friends as well. What I'm really excited about to do today is to talk with you about our research with the new disease of type 2 diabetes that we're seeing in children. And we're particularly interested in identifying nutritional factors that could be targeted in interventions for prevention and treatment. And so that's what I'm wanting to talk to you about today. And I'm going to go through the incidence of the disease. Like I said, it's a brand new disease. And so we'll look at some statistics, the treatment options and prognosis for adolescents and youth who have the disease. And then what has been done in terms of prevention strategies, particularly lifestyle and dietary interventions, some of which we have underway. And then I'm really interested in your perspective. So what are you seeing in your local environment for adolescents who may be at risk for type 2? And I'm happy to answer questions and at that time as well. And throughout, I should say, anytime you have a question, just go ahead and ask. So I try to move that a bit out of the way. So the statistics that I mentioned about the disease are shown here in this. They were obtained from a study called the Search for Diabetes in Youth study, which screened adolescents at 4 different sites in the US. And they did it from 2004 to 2012. And you can see the data at 2012, the incidence is 12.5 cases per 100,000 youth. And that number has been increasing over the years. The total population is shown here in the purple, but you can see that in subgroups such as Native American and non-Hispanic Blacks and Hispanics, you can see that the rates are even higher in terms of incidence. So that's concerning because we know that youth are developing these disease at higher numbers every year. So then the treatment prognosis was established in the study, the largest study of its sort, to look at adolescents who actually have full-blown type 2 diabetes. And the goal of the study was to look at treatment options that are typically used in adults and to see how effective they are in this population of adolescents. And so they randomized the adolescents. There were 50 per group. They were randomized to metformin alone, and then also metformin that was partnered with lifestyle intervention. So the standard lifestyle intervention that we see in adults, diabetes prevention and treatment studies, and then metformin plus the rosiglitazone, the TZD class of drugs. And that's what was available at the time as standard of care for adults. And what you're looking at is the number of months since randomization. So the study went out for 5 years, and they looked at the number of individuals that were free of glycemic failure, so had glycemic control. And as the value decreases, you can see that fewer of the participants had glycemic control. And the metformin group performed quite poorly in terms of treatment. The second group was the metformin plus lifestyle, and then the metformin plus rosiglitazone was slightly better. But basically, you can see that there was a lot of treatment failure, and the treatment was only effective for about 50 to 60% of the adolescents in the trial. So a lot of them developed hyperglycemia despite the treatment. And not only did they develop hyperglycemia, but they also developed complications. So within follow-up, when they looked at the follow-up of the adolescents past the 6 years and beyond, they found that there was development of hypertension, kidney disease, dyslipidemia, nerve damage, and all a combination of these microvascular diseases are all shown on this figure. So what they show in this figure is the length of follow-up, and then the when 50% of the population develops the complication, you can see that shown, the time that it takes is shown in the gray hatch bars. And so, for example, for hypertension, by 10 years follow-up, 50% of the cohort had developed hypertension. You can see for kidney disease, it was 15 years follow-up. And for all the diseases combined, you can see that by 9 years follow-up, at least 50% of the participants had developed some sort of complication, which basically says that if you have type 2 diabetes by age 15, then by 25 years of age, you're already starting to see complications develop, which really is a poor prognosis. And these are adolescents who are getting treated. So you can imagine what happens when you're not getting treated. This study compared the adolescents in the Today study with studies that are done in adults, which have also been providing treatment for type 2 diabetes. And so an ADOPT trial in the US, the US DOD study, and a study that was done in the UK. And it looks at the failure rate for the medication metformin or metformin and rosiglitazone. And you can see that in the Today study, there was much higher failure rates compared to the other studies that were done in adults. So this suggests that medications really don't work well in the adolescent population with type 2 than you see with similar studies in adults. And particularly concerning was the dramatic decrease in beta cell function that we saw in the Today study. So basically, in summary, then treatment for youth onset type 2 diabetes is not really optimal. And we see the complications develop earlier, and we also see that the adolescents are likely to lose years of life expectancy based on these complications, such as heart disease, kidney disease, and nerve damage. And so then we really thought that it's better to prevent the disease than to focus on treatment of the disease. Of course, we say that with all diseases, but for this disease, we particularly are wanting to prevent rather than treat the disease. And we know that prevention of type 2 diabetes is well established in adults, which involves lifestyle modification, and the cornerstone of which is to manage obesity, to cause weight loss through diet and exercise. And now we're starting to understand that other important factors are targets are sleep and other psychosocial factors that are important for health. And so being a nutritionist, I focus on obesity and diet. So we wanted to take a closer look at these factors in a cohort of adolescents. And so we know obesity is a major risk factor for diabetes. That's well established. And in particular, extreme obesity is the highest risk factor. It can elevate your risk by at least 20-fold if you have extreme obesity. And so looking at national statistics of obesity and extreme obesity in children, we see that the rates are rising in both categories. So we can see the rate of obesity in children is around 17%. It's been rising over the years. This is data taken from NHANES. When we look at extreme obesity, that's been rising as well. And I want to mention that extreme obesity is defined as having BMI that's greater than 120% of the 95th percentile. And so we see that that value is around 6% in youth in the US at the current time. In fact, it's actually a lot higher than that now. This is based on 2013 data. And so we know that this is certainly likely to be driving the risk of type 2 diabetes that we're seeing in youth. So we wanted to look at the prevalence of obesity and extreme obesity in our local population. And working with Dr. Larty, who is a postdoc that I had the fortune to work with, who's a health economist. She's actually currently now in the UK in her first faculty position. We had access to 70,000 electronic medical records that were collected between 2016 and 2020. And these were based on physician visits, pediatrician visits of children in our local area where they were heights and weights measured. So this was objective data collected from this population. And we used the data to look at a cross-sectional and longitudinal analysis to look at the prevalence of both obesity and extreme obesity in our area. And so the data from, this is cross-sectional data that I'm showing you going from 2016 to 2020, and of all the weight classes going from underweight, overweight, obese, and extreme obesity. And we did see kind of a flattening of the curves. So we don't see an increase in overweight, obese, or in underweight up until 2019. And then in 2020, we did see a jump. So we are seeing, and we base this on the COVID restrictions that were occurring during 2020, where children were not able to attend school or play in playgrounds. That we attribute to this rise in all the classes of obesity, but particularly we saw a statistically increase in extreme obesity that put the rate up to 6%, which is comparable to national levels. And so that's what we're seeing in our local population. And I'm showing you now some longitudinal data. So what we were able to do here is look at the transitions between the same population, in the same population between years. So we have the same population of kids that were going between 2017 to 2018. And we compared them to another population of kids that were assessed longitudinally from 2019 to 2020. And what we were interested in is whether there was a difference in the transitions between 2016 to 2017 and 2019 to 2020 to see if 2020 really was causing an increase, but now looking at it longitudinally in the same population rather than cross-sectionally. And what we do find is that for every transition of weight class, so for example, kids that were healthy in the healthy weight category that transitioned to overweight, when we looked at that in 2017 versus 2020, we do see that there is a higher number transitioning to that higher weight class. So we see that for healthy weight to overweight. We see that for obese to extremely obese. And again, it seemed like 2020, there was a higher transition of the same, the same kids transitioning between a lower class to a higher class potentially due to the COVID restrictions. So we are waiting to get the 2021 data, and we'll be able to basically see if we continue to see that trend, since they were still COVID restrictions in 2021, or hopefully if there was a reversing of that trend, because it's concerning that we're continuing to see an increase in obesity rates in our area. So this tells us that certainly there is a high prevalence of obesity and extreme obesity in our area. At the same time, we've been screening adolescents in our area for type 2 diabetes. I'm working with Tammy Hannon, who's based at the Youth Diabetes Prevention Clinic in Indianapolis. She's the director of that clinic. And I worked with Kelly Wagner on that study. I saw Japna smiling about that because I'm sure Japna remembers Kelly. And we screened 150 kids in our clinic. And I'm just presenting some data about the kids here. You see that their average age was 13, almost 14. There's slightly more females than males. We had nice representation from Caucasian Americans, African Americans, and Hispanics. We do see BMI Z-scores in the extreme obese category with high waist circumference. And when we looked at glycemic status, we saw that 52% of them had normal glycemia, but 41% of them had prediabetes, and naturally 7% of them had full-blown diabetes. So we are seeing this population that's represented nationally of adolescents with prediabetes at a fairly high rate, and of full-blown type 2 diabetes in our local population. So this led us to believe that we should be thinking about lifestyle modification to prevent type 2 diabetes. And we were guided by a very nice study, and this is one of the very few studies that have actually done lifestyle intervention for diabetes prevention in youth. This is called the Bright Bodies study. And what they did is they found kids who had prediabetes and randomized them to either having an intensive lifestyle intervention, very similar to the diabetes prevention program, where they brought them into an academic setting and they had group-based counseling for diet and also physical activity, which was supervised. And that was compared to education only. And this is the data that the Bright Bodies study provided at 6 months follow-up. First, you can see their glycemia during an oral glucose tolerance test was pretty similar between the two groups at baseline. But then the lifestyle group actually saw at 6 months a decrease in their glycemia, showing that lifestyle does prevent type 2 diabetes from occurring in adolescents who have prediabetes. And so again, this program really focused on promoting weight loss in the intervention. But interventions with obesity are weakly effective. This is a systematic review and meta-analysis of data taken from 76 studies which were randomized controlled trials, all using behavioral interventions in children and youth. And the forest plot is shown here. Overall data looking at the standardized mean difference between the interventions shows that there's a very small decrease in BMI in the 76 studies. The BMI decrease was only 0.09. And this is significant, but it's very clinically very insignificant when it comes to the effectiveness of this type of weight loss in adolescents. And so we were able to note that obesity is a very tough target in adolescents based on this data. And so we were interested in maybe focusing on diet interventions and to see whether we could tweak diet in order to see some effectiveness for diabetes prevention. Of course, ultimately, we're interested in looking at physical activity and sedentary behavior and sleep and other targets as well. But we are starting with diet to see what we can learn about factors that can be strategies for intervention. So we did this through our dietary intervention study, which we call Dietary Intervention for Glucose Tolerance in Teens. And this is our dietary prevention program, or diabetes prevention program, I should say, called DIGIT. And for DIGIT, we assess adolescents who have obesity, and then we look at their diet very closely, as well as other risk factors. And I'll tell you about how we measure diet very shortly. We then screen them for diabetes, and those who have prediabetes are randomized to either having a health coaching intervention or a single dietary consult with a dietitian. So that's the comparison group. We look at them at 6 months and 12 months after a health coaching intervention, which is done every week for the 6 months. The health coaches meet with the participant and also with their parent or guardian, and then we assess them for 6 months follow-up. I'm showing you some baseline characteristics here. Oops, I'm trying to get rid of that. I don't know how to get rid of this. Maybe I'll move that somewhere else so you can see. Well, can't seem to get rid of that, but
it's not in our way. It's not in my way. Maybe it's in yours.
Oh, okay. Well, that's good. Okay.
Anybody else? Is it?
No, I think it's all
You can
good.
see everything clearly.
Looks fine.
We're good.
Good. All right. So basically what I'm showing you is some baseline characteristics just to be able to see some information on the metabolic characteristics of the participants and comparing that to reference ranges. So again, our average age range for the kids who we've screened in DIGIT is around 15. They're equal in male and female. I forgot to mention that we've divided them into the group that had normal glycemia and the group that had prediabetes. So about 45% of them had prediabetes of the ones that we screened. We do see that they are elevated in their obesity. They fall in the extreme obese criteria category, elevated in waist circumference. Their total cholesterol falls within the normal range, but they do have hyper LDL and hypo LDL, and their triglycerides also seems to fall in the normal range. So then when we look at their glycemic status, as we would expect, they are, well, I guess there's various criteria for glycemia. We looked at fasting glucose, hemoglobin A1C, and 2-hour glucose. We found them fairly comparable between the normal and the prediabetes group in terms of fasting glucose, hemoglobin A1C as well. But we did see that their 2-hour oral glucose was higher, which does meet the criteria for prediabetes. So that's why they fall in the prediabetes group. So they're basically a group of adolescents with impaired glucose tolerance. When looking at other measures of insulin action, we see that their hemoglobin, their HOMA-IR, their measure of fasting insulin resistance, is comparable between the two populations, but it is quite high. So they do have a lot of insulin resistance. They also have very low insulin sensitivity when you look at the whole body insulin sensitivity index. And they also have particularly the group with prediabetes has very poor insulin secretion and very poor beta cell function. So all of these are what you would expect. They mirror what we see in adults with prediabetes in terms of not only their glycemia, but their insulin action as well. And so I'm just showing that data to kind of show you that they do meet, they do have the pathophysiology that we would expect to see with adolescents or with people who have prediabetes. This data is very recently acquired interim analysis for our cohort of 20 adolescents who were randomized into the health coaching or standard of care. Unfortunately, we have been stalled with DIGIT for the past 2 years. We haven't been able to recruit since I left Purdue, and then we had COVID. So we're really just now looking at what we've done so far with DIGIT, which is randomized 20 adolescents to the health coaching or the standard of care group, and looking at the data that we have for the results at 6 months. You can see that there's a decrease in fasting glucose. It wasn't significant, but we did see a significant decrease in hemoglobin A1C. Interestingly, there was no change between the two groups. 2-hour glucose may be decreased as well, but there's no significance here between the two groups. And BMI, there was no change. Waist circumference, similarly, we don't see a difference between the two groups. So essentially, what I would like you to take home is that the groups aren't worsening in terms of glycemia while they're either in the health coaching or the standard of care intervention. So that the standard of care being a single dietary consult. So, I mean, that's promising for the group. We're feeling that we are at least not seeing a worsening of glycemia during the time they're with the study. We have learned a lot from this population, despite not being able to really fully see an effect of health coaching or finish the study over the past few years. We've learned a lot about their diet, and that's what I want to spend the rest of my time showing you, what we've learned about their dietary factors. But first, I want to start by saying it's well known that adolescents have the poorest dietary profile of the age groups in the US. This is showing that data from NHANES, where you can see we're looking at dietary score, the healthy eating index score, which is a measure of the quality of diet. So the higher your score, the better quality your diet. And a score that's below 50 is certainly a very poor diet, which is what we're seeing for the adolescent population. It's shown here in the purple and the green bars. That's the adolescent population. And that's the group that is showing us a failing grade when it comes to diet quality. So we expect that we could have lots of room for improvement when it comes to the adolescent diet. And when we look in the literature, and I'm showing you several observational studies here where they've looked at associations between foods and nutrients and glycemia or diabetes risk. Again, these are observational studies only, but these studies all point to an association either promoting or reducing the risk of type 2 diabetes. The studies that are shown in yellow were studies that were done in children. So we showed, for example, that eating more fried foods or eating more desserts was related to increased association with glycemia. Colleagues in Edmonton showed that increased fat led to higher risk of diabetes and metabolic syndrome. And Wang and colleagues looked at children and found that increased intake of sugar-sweetened beverages was promoting the risk of developing type 2 diabetes. The rest of the studies have all shown that either similar relationships between increased fat and a positive effect on type 2 diabetes, or a decreased polyunsaturated fat and a negative effect, meaning less risk of type 2 diabetes, or benefits from taking whole grains, fiber, magnesium and chromium and potassium, all showing a reduced risk of type 2 diabetes in association studies. And on all these studies, they independently controlled for obesity. So all of these factors are independent of the effect that obesity has on promoting type 2 diabetes. And this is just some of our data on this, where we looked at consumption of desserts and risk of, an increased level of glycemia in the same cohort that I showed you earlier, where we had adolescents who were consuming 3 or more desserts per day, actually had higher oral glucose tolerance test values at 6 months. Excuse me, this is cross-sectional data. So adolescents who consumed 3 or more times desserts per day had higher oral glucose tolerance test values compared to adolescents who consumed 0 servings of dessert per day. And again, please stop me if you guys have questions throughout. So I see that there's some chats questions, and I don't know if I should take time to look at those, but just jump right in and talk to me if you want me to slow down or have a question. I'm now shifting to some clinical trial data where experimentally nutrients were manipulated and there was an effect on type 2 diabetes risk. So these are, more showing you a cause and effect relationship than the studies I showed you, which were observational. And there have been studies showing that if you manipulate added sugars experimentally, you do see an increased risk of type 2 diabetes. Typically, they're looking at biomarkers of risk as opposed to actually, the onset of type 2. Studies have also shown that if you increase saturated fat, there's an increased risk of type 2 diabetes. Fiber has shown to decrease risk, and so has magnesium been shown to decrease risk. And again, all of this is independent of changes in weight. So this promoted our view that maybe we can manipulate diet and see some benefits without really having to target weight loss. I'm also showing you, to prove that point further, data from the Today study. So this is data from an adolescent study of adolescents who actually had type 2 diabetes, where they were intervened using lifestyle intervention. So that's the study I showed you earlier. Lifestyle intervention wasn't particularly effective in reducing their glycemia, but for a subset of adolescents who increased their fitness or increased their fiber or decreased their saturated fat, we did see some benefits on their glycemic levels, so that, when in males, they increased their fitness, there was a decrease in hemoglobin A1C. And in females who decreased their saturated fat, there was a decrease in hemoglobin A1C. Similarly, an increase in fiber in females was associated with a decrease in hemoglobin A1C, and an increase in added sugar was associated with an increase in hemoglobin A1C. So these are all, again, suggesting that dietary targets can be beneficial in glycemic control. So we developed this conceptual framework based on all of this evidence. And our thoughts were that if we have adolescents who have obesity, and certainly would have then increased risk of type 2 diabetes because of insulin resistance and beta cell function, we can manipulate diet either through health coaching to help adolescents have a healthier lifestyle, or reducing added sugar, or even providing things like magnesium supplementation. And so that's the framework that's guiding our current studies. And I'll show you what we've been able to do with the health coaching study first. And then we'll show you some work on the added sugar. First, I wanted to make the point that when you look at national data, you certainly see that adolescents are consuming excess amounts of added sugar, primarily from sugar-sweetened beverages. And so we're really targeting intake of sugar-sweetened beverages in our current studies. And so the recommended levels are no more than 100 kilocalories of added sugar from in your diet, and adolescents are overshooting that by at least 100% when you look at males, and almost that when you look at females. So we do see that boys and girls are consuming too much added sugar from sugar-sweetened beverages, and so that certainly helped us think that that could be a target that we could go after in our intervention. So we have really carefully characterized dietary intake in our adolescents. We used an app that was developed at Purdue where they use a phone to take images of the meals before and after each meal. And so these are images that are shown here, and we use that to create a food record of the adolescents. We find that that is something that they're able to use much better than creating a paper diary. And so we are using that to characterize the diet, and I'll show you the data that we've been able to create using the TADA app. So for 31 kids that were enrolled in DIGIT, this is what we've been able to characterize about their diet. We see that majority of them, in fact, 99% of them are over consuming their range of saturated fat that's recommended. Same with added sugar, under consuming fiber compared to recommended levels, only getting 1 cup of fruits per day compared to 2.5, which is recommended, and only getting 2.2 cups of vegetables compared to 2.5 cups per day, which is the recommended amount. When we look at the intake of sugar sweetened beverages and we compare that to their glycemic concentrations, we see that adolescents who are consuming 1 or more serving of sugar sweetened beverages per day have the highest level of 2-hour glucose following an oral glucose tolerance test. And we didn't see any differences in HOMA-IR. Again, remember their insulin resistant values are pretty high when you look at the overall cohort. So maybe it's not too surprising that diet wasn't affecting that further. Just going back to the DIGIT study, looking at 6-month data and the group that was undergoing the health coaching versus the single dietary consult, we saw that there were changes in diet that we were able to achieve in the both groups, actually. I should say, when we look at the group that was undergoing the health coaching, we did see that there was an increase in vegetable intake, where we did not see that with the group that had the single consult. And when we look at added sugar, we did see that there was a decrease in percent of energy for added sugars in the health coaching group compared to the group that had the single consult. And again, this is interim analysis. We would love to go further to complete the study to see what we get, but we are hoping to start recruiting. I'm actually looking for a grad student to help me with that study. And so hopefully we're successful with that as well, so that we can continue with our work with DIGIT. But we were encouraged by seeing that there was an increase in vegetable intake and a decrease in the added sugars in the group that was undergoing the health coaching intervention. So just summarizing the data that we have with DIGIT, basically we've shown that the study is feasible. We were able to screen 48 adolescents. We certainly know we have the access to the population. From that, we were able to randomize 29 into the intervention. We've completed 20. We do have, I'm not too happy about the 70% retention. We could have a higher retention, so we need to work on that as well. But we have been doing this study without any federal support. We've been kind of cobbling together funding from internal funds and help from grad students, which have been really essential to make the project run. So we are constantly seeking federal support, and maybe we'll be successful there with this, what we think is really an important population to be working with. Basically, we do see that glycemia is reduced just by being in the study, especially when we look at hemoglobin A1C. And even more important, we don't see any weight loss, but yet we do see some improvement in glycemia. So this tells us that we can possibly intervene on diet without having to target weight loss and see some improvement in glycemia. And then, of course, as I mentioned, we were able to see an increase in vegetable intake in the group that was undergoing the health coaching. So now I'm transitioning to look at other interventions that we've done targeting added sugars. And in this study, we were targeting the high consumption of sugar sweetened beverages that I'm showing you in that slide. And so I've been working with Dr. Corey Running at Purdue, and we had this exciting theory that drinking sparkling waters, which are shown here, can actually help people to reduce their preference for sweetened beverages. And so Corey's hypothesis is that the carbonation in the sparkling waters can make flavors taste sweet, even though they don't have either as much sugar as you see with the sugar sweetened beverages, the Coke can that is shown here, or they have a reduced amount of sugar. Either way, they still provide a flavor of sweetness without having those added sugars there. And so we've been testing that hypothesis in an intervention that I will show you in a minute. And again, you can see that there's 39 grams of sugar in the can of Coke. The equivalent flavored cola, which is here in the seltzer water, has no sugar, but yet individuals can learn to find these flavors acceptable without the sweetness. So an intervention that we started right before COVID, we hypothesized that we would randomize 16 children into drinking, excuse me, I shouldn't have said randomize. We would do an observational study here where we would give adolescents sugar sweetened sparkling waters for 12 weeks. And we would look at their perception of sweetness at the end of the trial. So this was not a randomized study. This is just observational. We looked at before and after effects of giving the adolescents the sparkling water. And we were also hoping to look at glucose and insulin sensitivity, but then COVID happened. So we had to abandon that aspect of the study and do the whole study remotely by just looking at sensory testing and looking at the preference for sweet flavors in this study, rather than look at the glucose tolerance and other things that we were hoping to do. Working with a grad student, we were able to make our own carbonated beverages in Corey Running's lab. And so this is the kegs where we were able to create the sparkling waters with different concentrations of sugars. And that's what was used in the sensory testing. So we did all of that in-house. And then Vinny Valicenti took over and did the study where he conducted the whole thing remotely. And we looked at the sweetness preference over various different concentrations. So what I'm showing you here is the preference before they were given the sparkling waters for 12 weeks and the preference of sweetness after they were given the sparkling water for 12 weeks. And for every concentration we tested, you see that after the intervention, they felt that the flavor was more sweet. So that was really in line with Dr. Running's hypothesis, is that being exposed to these sparkling waters conditions people to prefer a less sweet concentration. And so we are following that up with a lot of grant writing to see whether we can attract some funding to actually do the study that we hope to do before COVID, essentially giving people the sparkling waters and looking at their glycemia to see if that actually reduces, because we can shift them to prefer the sparkling waters rather than sugar sweetened beverages. So that's underway. That's our study there. Just to finish up, the last thing we want to do is look at supplementation. We're working towards giving magnesium as a supplement. So we're doing some studies looking at magnesium absorption, just to identify the best supplement that we want to use for that study. And we hope, again, to maybe tweak their insulin sensitivity by giving people magnesium and seeing a decrease in their diabetes risk. And so then, just to basically wrap up, I wanted to thank all the collaborators and students. I tried to mention them throughout the talk. And we have several collaborators, both at Purdue and Indiana University. And we've received a lot of internal funding, some foundation support. And we are constantly seeking federal funding for this project. We hope that because it's such a significant project, that we will eventually be successful with that. And so I'll stop sharing my screen, and thank you for your attention. And I look forward to hearing about your perspectives. We're working with such a cohort, and I've heard a little bit about that from Dr. Parks earlier today, but I look forward to hearing more from you about that and answering some of your questions.
Thank you so much. This was such an excellent talk, and I'm so excited to see all the great work that you're doing. It really is. It's fascinating.
Thank you, Japhna.
Okay, so we have a few questions in the chat. I can read those out for you. So Dusty asks, we know that sex hormone status affects pre and post menopausal women in terms of adipose tissue metabolism and insulin resistance. Are there any data you know of that associate type 2 diabetes in adolescents or kids and Tanner puberty scores?
Yeah, that's a really good question. So puberty has a major effect. That's a risk factor that we're certainly trying to track. We're for sure, tracking their, gender. And we expect to use statistical techniques to really identify whether there is a separate risk of both gender and also puberty status on glycemic risk. It's really interesting because we see a lot of adolescents with prediabetes, but only about a third of them will develop full-blown diabetes if it's not treated. And so maybe there is some issue with gender, or maybe there's some issue with puberty status that will impact that. And so we're trying to understand that. Those are things that we're definitely tracking. So we do have a Tanner scale in our measurements panel that we do to phenotype their puberty status as we're doing the study.
Thank you. So the next question is, in the DIGIT study, did you collect data regarding the parents or the guardian's weight status, diabetes status, diet quality? Are the children or teens independently making worse food choices, or is it what's available at home?
That's a great question, Talia. We are looking at that as well. We have about 14 questionnaires that we have the adolescents do, and we have them do it while they're doing their oral glucose tolerance testing. So we have them captured for 2 hours, and we just have them fill all these questionnaires. And a lot of them are behavior, and not only on the behavior of the adolescents, but also their family members. So we ask them about the family members about self-efficacy for following healthy diets. And we are also looking at their overall health status. And we do think that there's a relationship, although we haven't analyzed that yet, between parents' health status and children's health status. So we don't think that children are independently making decisions that is influencing their risk. We think it's very much driven by their home environment. And what I wanted I'm glad you asked that question, because one thing we really struggle with DIGIT is that the health coaches are supposed to meet with not only the adolescent, but also their parents as well. And we find that that a lot of times the parents will be thinking, well, here we have an intervention for you. You do this intervention, and we'll just continue to do what we're doing because we're not needing that. We don't need that assistance. We'll keep going out to eat, or we'll, do whatever behaviors we've been doing all along. And we're really struggling to try to get the whole buy-in from the parents. We need more. I don't know what is needed exactly there. And I was talking with Dr. Parks about there's a lot of behavioral aspects to this that fall outside of my expertise. But we are hoping to really engage the parents better, the parents and guardians better. We're finding that that's quite tough.
Are these health coaches dietitians?
Yes, they are. They are. So we really focus on diet. One thing that we realize is that physical activity is a major target as well. Our adolescents are very sedentary. And we don't really have an answer for that in the intervention as well. So they're actually getting about 8 to 10 hours of sedentary behavior a day, which is way outside the no more than 2 hours that's recommended. And so we know that that's a target that we should be addressing as well. And but we haven't figured out, there are dietitians, and so they're focusing on diet. Yeah.
So not as much physical activity promotion and.
Yeah, of course we tell them, but like whether we give them strategies for that, I don't see that we're doing that. In fact, our interim analysis is not very positive in terms of effects on physical activity. I'll just say that we don't see an improvement at all.
Okay, thank you. A similar question, Grace asks, have any studies considered the economic status of the family?
Yeah, again, we have a food insecurity questionnaire that we have included in the panel. And so that's what we've done there. I think we have a SES questionnaire as well. I would imagine when we analyze that is a big part of their health status, and their even maybe ability to do well with the intervention. Certainly that's what's been shown with the Today study. The adolescent population was particularly one of a lower resource, lower socioeconomic status. And those were the ones who really didn't respond to the Today intervention in terms of both medications and lifestyle intervention. So we think that's a big factor that needs to be addressed. And again, I'm not sure that we are particularly addressing that. It just really highlights how important, interventions have to be, not how important, but how multi-component they have to be, right? There's that framework that is escaping me at the moment, that is the theoretical framework, I think, for addressing multi-levels of behavior, not only the person, but also their family and then their environment.
Right.
Socio-ecological framework is what I was trying to remember. Yeah, I think that needs to really have a benefit. We need to be thinking that way.
That's very true. When I was at UC Merced, we did a study examining, just the sensory perceptions and preferences for fruits, vegetables in this cohort of students who are working, who are at this food desert campus. And in that study, so we actually, the manuscript, we're going to submit that really soon. So we are seeing associations with food security status and, perception of financial stability with preferences for fruits and vegetables. So there is something there, definitely.
Yeah. I think it's hard to optimize your diet when you're dealing with, lower resources for income and access to food and all of that. So whoever can figure that out will really be able to design a very optimal intervention, I think.
True. Okay, Catherine, do you want to ask your question?
Yeah, so I asked this question because I know, Nana, you've worked with the bariatric surgery population. So I wonder what your take is on surgical management of type 2 diabetes, considering that there's data to support the remission of type 2 diabetes in 95 to 100% adolescents. And in that same token, who is better suited for surgical management of type 2 diabetes, considering the negative consequences of non-compliance to post-operative nutritional recommendations?
Yeah, so thanks for that. Good question. And it's such a struggle to have an answer to that question, because you hit the nail on the head. Surgical management, that is definitely the most effective. And it has been shown for adolescents as well. Surgery will ameliorate type 2 diabetes. On the other hand, I get nervous thinking about that because of the nutritional complications. I mean, these are going individuals. We know how important it is for them to get their vitamin D and calcium in those, particularly calcium in those years of skeletal growth, trying to lay down peak bone mass. That's going to be a problem if they have bariatric surgery. They're not able to get enough iron. There's a huge amount of iron deficiency. many other nutrients. So I think I really struggle. I feel like, on the one hand, preventing complications, as I showed you, within 10 years of developing type 2 diabetes is important. But on the other hand, there's nutritional complication, and we have not been able to optimize nutrition for people undergoing bariatric surgery. There's a lot of work that needs to be done there. So I don't know what to say.
It's a complicated one. I agree.
James has a very interesting question. He asks, at what age do you recommend talking to your children if you notice that they're gaining too much weight? And what's the best way to go about this? Many parents seem to have a mindset that they'll grow out of it.
Yeah, again, which is why we need all these professionals with expertise in weight management that maybe aren't just focusing on weight. I mean, that's why we were kind of leaning towards not talking about weight, but just focusing on diet as a target. But it is, I mean, again, weight loss is about the best treatment for prevention, right? So I think having people who are sensitive to that and understanding that you don't want to create disordered eating while focusing on weight is important. And I'm not a professional there, but I just feel like that's something that has to be addressed.
Yeah, I agree. Talia has a question on magnesium supplementation data that you presented or talked about. So are the teens or the children that you're studying, did you notice if they're deficient in magnesium currently, and are you assessing mineral or vitamin status through blood samples or?
Yeah, we haven't done that yet either, but that's a great question. We would like to look at magnesium status. If magnesium status is hard to assess, we're working on that as well, because magnesium is intracellular as opposed to extracellular. So looking at plasma levels of magnesium isn't ideal. And the actual test to look at magnesium status is going to require IV, and that's not something that's done typically. But when you look at diet as a way of assessing magnesium status, you see that many people, adolescents for sure, and certainly adults, are under consuming magnesium. So it's one of those nutrients of concern. And so we would expect that magnesium could be improved, magnesium status could be improved, but whether it has been shown to be actually deficient or not, I'm not sure.
Dr. Padilla, do you want to ask your question?
Sure, I can ask. First of all, greetings from another IU alumni. I did my PhD in kinesiology next door from you.
Great.
I have great memories of Bloomington. My question has to do with have you calculated how much weight loss would you encounter if you were to remove the sugar-sweetened beverages from their diet and everything else was kept the same?
I wrote a grant.
Calculations.
Yeah, I wrote a grant.
In best case scenario, what would be the weight loss that you would encounter with this intervention over a period of time?
Yeah, so I mean, if they're consuming around 300 calories per day of added sugar, and they reduce that by 150, I'm blanking on how much weight loss that would cause, but it would cause substantial weight loss. I mean, it would cause weight loss over time. So it is a significant amount of calories. And I wrote a grant recently where we actually have an intervention where we would shift adolescents from sugar-sweetened beverages to artificial sweeteners. And we did expect weight loss from that. And we do expect there would be a reduction in glycemia as well. But I'm blanking on how much weight loss it would be. I'm just going to guess around 6 pounds or so.
Yeah. Can I chime in? David Ludwig did this by delivering water, basically, to try and get people to and children to reduce sugar sweetened beverages, and they did. And then Jean-Marc Schwartz tried to take sugar sweetened beverages out and replace them with complex carbohydrates. And he tried to keep people weight stable, and he was unsuccessful. They lost weight anyway, which is really fascinating. And that was the only change he made. And he controlled the diet. He gave them the food. So taking the liquid sugars out and replacing with complex still caused weight loss, even though that wasn't his goal, which was a bit of a problem for him. But yeah, Jame, people, our patients, I've worked with patients in the past, and all you do is remove the soda and weight begins to come off, like they're not even trying. And is it Nana, because it's extra calories, right?
Yeah, and that reminds me of some work at Purdue. Rick Mattis has done some work showing that people don't compensate for drinking calories. You know, they don't feel full and stop consuming extra calories because that is almost like it's not noticed as extra calories coming in when it's liquid calories.
Yeah.
Great, thank you.
Okay,
I don't think anybody switched, like you're saying, to non-nutritive sweeteners.
Yeah, we're hoping that there's a gap there that we can address. Yeah, so we'll see how that grind goes.
Very cool.
Dr. Miller, one question that I have is, so in the last study, that the one that Vinicius did, that it was remotely, the fact of sending them the drinks, like make it like a free available, I started thinking about this will affect the decision process of them because they're going to have free drinks. So I'm not going to take soda because I have this free one. And I was thinking, how do you control for that? We're going to send them both. It's an amazing idea, by the way. I like it, but I was thinking about it's problematic.
Yeah, no, that's a great question. I think that is actually what it's a behavioral study in that we're not really trying to control. I mean, we are actually, that exposure itself is the intent. In fact, the way Dr. Running envisioned it is that we would give them all kinds of benefits we give them the drinks, we give them coupons to get the drinks and all kinds of things. And then we would follow them up later after all of that stopped to see if they would go out and do all of that on their own. So it's a way of really modifying behavior rather than trying to really see whether, I understand your question. I think, you know, you're thinking of the perfect control study where you have them drink the sugar sweetened beverages and also have them drink the sparkling waters. But in this case, we just wanted to just see if just the exposure itself would make a difference in their behavior.
Yeah, no, I think that's what I think would be even pretty potential, because if you're able to provide them the drink, no matter what, and they're able to change their behavior, it's basically a treatment. So I think it's pretty interesting, this idea. I was like, oh, this is pretty nice. Simple idea, but it's really interesting.
Yeah,
nice.
Yeah, that's the kind of idea that's why I really like working with Dr. Running, and I know Japna knows her really well. She's just really brilliant at coming up with ideas like that and just leveraging taste and how sensory preference can modify behavior.
Nice. Thank you.
Mm-hmm.
All right. Well, thank you so much, Nana. This was it was really a pleasure to have you. And we lost track of time because people had so many questions. They loved your presentation. But let's give Dr. Gletsu Miller a round of applause for her fabulous presentation. Thank you so much.
Well, thank you.
And
for
I
the
wish
interest.
we could have had you over in person, but maybe we have an opportunity sometime next year. We'll definitely love to have you over again.
I would love to come. Yeah. Thank you.
And we're so close. So, you know, it's not like you're flying in from California.
Yeah, next time I would drive. That's what I would do.
Yeah.
Bye.
Bye.
Thank
Thank you
you.
so
Bye.
much.
Thanks so much.